Hi, this is Dr. Krishna Deepak, and welcome to another episode of Stethoscope Sip, short for Stethoscope and Sip. This is a unique podcast by a doctor to a doctor for doctors. And today, our guest is none other than Dr. Ricken Mehta. He is an ace nephrologist from the city of Bangalore. Let us welcome Dr. Mehta to our podcast. Sir, welcome to our podcast, sir.
Hi. Thank you. Thank you for the warm welcome.
So, sir, tell us a little bit about yourself. Where are you from? Where did you do your MD, DM, and presently where you're working? What is your area of interest?
So, we are basically Gujaratis. My father hails from a small town in Gujarat. However, I was born in Pune,
Okay.
and then my father, due to his business reasons, shifted to Bangalore when I was in class 2. So, since then, I have been in Bangalore, very much a Bangalore boy since then. Did my schooling in Bangalore, did my MBBS again from Kempegowda Institute of Medical Sciences in
Okay.
Bangalore.
Okay.
So the journey began in 2006 when I joined MBBS. Very unlike for a person from the business background to join MBBS, but yeah, destiny had it so. So here I am. So 2006 to 2012, I was in Kempegowda Institute of Medical Sciences, following which I did my internal medicine from Bangalore Medical College, which was at that time associated with Victoria Hospital and Bowring and Lady Curzon Hospital.
Very good.
So I finished my MD internal medicine there and took up my nephrology in 2017, which I did again from Victoria Hospital from the Institute of Nephrology.
Okay.
And after finishing my DM in nephrology, I served there for one more year as an assistant professor in the Institute of Nephrology, following which I started my private practice.
Wow.
So 4 years I was affiliated with a private hospital, that is Blue Bliss Hospital in Bangalore.
Okay.
And now currently I am heading the department of nephrology in Saptagiri Super Speciality Hospital as an assistant professor.
Wonderful. What was your thesis in during your DM?
So a very interesting question that you ask because yeah, so when I did my DM, uh, I mean, is it you're asking about the DM nephrology or
Yes,
MD internal medicine? Okay, so in
DM nephrology.
nephrology, my thesis topic was on the clinical profile of patients with POSI immune glomerulonephritis or
Okay.
ANCA associated glomerulonephritis.
Okay. And what was the conclusion or the thesis endpoint that you?
Which we conferred. Yeah. So
Yeah.
basically, we were trying to look for what kind of patients are developing this post-immune glomerulonephritis, whether there is male preponderance or female preponderance, any particular
Okay.
regional predilection is there.
Okay.
And of course, based upon what the biopsy findings are, we
Okay.
need to understand. I mean, what are the clinical profile that they are coming to us with, what are the biopsy findings, and what kind of treatment we used on them, and
Okay.
what kind of outcomes we could get in these kind of patients with post-immune glomerulonephritis.
Okay. Great.
So yeah, that was
It's
something interesting.
I'm sure we can talk entire today's podcast on this aspect,
Correct.
but it won't serve any purpose.
Absolutely. Yeah.
So, coming back to the basics, see, I think there is a big resurgence in the incidence and prevalence of chronic kidney diseases in our country.
Absolutely.
Uh, Apart from diabetes and hypertension, because those are the most common causes.
Right.
What is the next most common or next three most common causes in your experience that you have seen?
Right.
If you can elaborate.
So as you rightly said, that the prevalence of chronic kidney disease in India has been increasing. Every 10th person or 1 in 10 individuals are having chronic kidney disease. And as you already mentioned, diabetes and hypertension being the leading causes, we have become the diabetic capital. And unfortunately, that is leading to an increased number of CKD. But yes, apart from these two conditions, we have other conditions like stone diseases,
Okay.
calculi in the kidneys or anywhere in the urinary tract are leading to chronic kidney diseases. There is something called chronic interstitial nephritis, which is due to variety of causes. One common cause being painkiller medications. A lot of population of patients are taking over-the-counter painkillers and other medicines which are nephrotoxic,
True.
which are causing chronic interstitial nephritis. Cystic kidney diseases. There are, of course, though we only look at the ADPKD, that is the autosomal dominant polycystic kidneys, as one of the common cystic kidney disease, but there are other cystic kidneys as well, which are leading to end-stage renal disease.
Okay.
And we have a lot of glomerular diseases,
Mm-hmm.
most common being IgA nephropathy.
Yes.
So whenever we get a glomerular disease, which is not due to diabetes, most of the cases are due to IgA nephropathy. And unfortunately, this is not recognized in the early stages
True.
because we lack the screening programs for that. The school health checkups or something like that is not there.
Okay.
So unfortunately, the stage when they are having hematuria is missed.
Mm-hmm.
And they get picked up only when they start developing hypertension
Mm.
or renal failure.
So, in a school-going child, if you see CAS and if you see in a simple CUE with and transient hematuria with CAS, you feel that we should evaluate further.
See, I've always had this idea that the only best way that we can prevent the progression of these kidney diseases, especially something as common as IgA nephropathy, is having the screening programs at the level of the schools.
Okay.
When you do a simple urine routine examination, if it shows any sort of a microhematuria, as you mentioned, or some amount of proteinuria, definitely it should be evaluated. So complete evaluation plus or minus a renal biopsy may be the way to go forward. Sometimes at that stage, they may have a normal renal function. But that is the time when we want to pick it up actually and treat it so that you can prevent the progression to a CKD stage 1, 2, 3, 4, 5.
Yes, true.
Right. So
Wonderful. Recently, during my course of study, especially with my current role as a medical advisor for a pharma company, I came across the new KidGo guidelines.
right.
So my focus in that, it's a big document,
Right.
but mainly mine was about the ferritin and transferrin and iron part.
Absolutely.
So I have gone through that, and the goalposts have been moved a little higher. Higher ferritin values. Also, they want to give iron infusions. What about general nephrology? Are there any drastic changes from previous KidGo guidelines to newer KidGo guidelines? Anything which has come in general, not very specific, something which has caught your attention,
Right.
like a 180 degrees
Turnaround.
kind of guideline change has happened.
Right. So, frankly, I mean, most of the things are usually a modification of the previous guidelines, as you said. There'll be a pushing of the limits or something like that. Like recently, they say the blood pressure cutoffs. From whatever we used to study when we were MD internal medicine at 140/90. Now they've brought it down to 130/80 and now even 120/90 and stuff. So, the cutoffs, they start reducing the cutoffs. They want to maintain a lower cutoff value for blood pressure, especially in patients having, glomerular nephritis. 130/80 at least is what the cutoff is being now followed. We want to maintain the blood pressure below that.
Okay.
Apart from that, the other thing in dialysis population, especially what they have, after an important study, which is called the pivotal study, done in 2019, they've started moving that, giving proactive iron to patients on dialysis versus giving reactive iron. So when I say proactive iron, meaning a patient who's on hemodialysis, irrespective of their iron profile, you give them some amount of iron every month.
Okay.
Around 400 mg is what they've given. Iron sucrose they've used there. So they are giving 400 mg every month. And unless, of course, there are certain cutoffs, safety cutoffs of ferritin as well as transferrin saturation. So if the patient is within those range, you give a proactive iron every month. And you see how the patient is responding. Certain primary outcome points, cardiovascular outcome points have been taken, and what ESA requirement will be there in those stages it is taken. And at the same time, they've compared it to those patients who have received reactive iron. That is, only those who had iron deficiency. Based on the iron profile, they have given smaller doses of iron, right? What they have found is giving proactive iron has definitely been beneficial in the cardiovascular outcomes as well as in reducing the dose of ESA requirement among
I have
these
seen
dialysis
this
patients.
report, yes.
Yeah, so that is another important and interesting change which has been brought out in the newer guidelines.
That what I've seen was for more with FCM, ferric carboxymaltose.
Right. So in this study, what they had done was iron sucrose, which was used at that point of time. 2019, it was released. But the same thing can be extrapolated to any
Ferric
form of
carboxymaltose.
iron. Because, for example, you're giving 400 mg of iron sucrose, that versus giving direct 500 mg of ferric carboxymaltose once a month. So it makes it easier because you can't keep doing iron profile for all your dialysis patients every month. It becomes an expensive affair. So rather, it's easier to give them iron, IV iron, unless they have very high, transferrin saturation ferritin. Maybe once in 3 months or once in 6 months, you can repeat the iron profile. But give
Okay.
them proactive iron, and that will help in reducing your erythropoietin dosages as well.
True.
And helps in ultimately achieving good cardiovascular outcomes, because when the iron is there in the body, the erythropoietin can act and improve the hemoglobin levels. Automatically, their cardiovascular outcomes will be better.
True. And one thing is, because CKD is a chronic inflammatory condition,
Correct.
oral absorption of iron is not very
bad.
good,
Yeah.
and you have to rely on IV parenteral preparations. That is true. So you deal with CKD patients left, right, and center.
Absolutely.
And the bad word or the bad letter here is D,
Dialysis.
HD or D.
Yeah.
How do you prepare your patients for hemodialysis? How do you counsel them?
Yeah.
At what stage you start preparing them?
Yes. So it's a very, again, another interesting question. Unfortunately, I have struggled to do it at some stage. So when we were doing our post-graduation, we had a lot of patients in our OPDs. We did it from a government institution, and the kind of load that comes to government hospitals. The patient is in front of you, and they've come back with all the reports that you've asked for, and based on the reports, either the ultrasonography or the low hemoglobin along with high PTH levels, we would have probably assessed that patient is now in chronic kidney disease. Sometimes the creatinine is 4, 5, sometimes it's 7, 8, and within that 10 or 15 minutes time, you have to actually bring that matter out in front of the patient and the family that your kidneys have failed, and you probably will need dialysis in the future. And that will be a lifelong process. Or you may have to go for a renal transplant. But the first thing would be, definitely you will have to start on dialysis. So explaining this in a very short period of time
It's tough.
is very tough. And unfortunately, we have to all do that at a lot of time. On a lot of occasions, we've done that. But yes, so now currently what I practice mostly in my clinic, because of the time that I have, probably I can give more time to patients over there when compared to a setup where I'm time constrained. So I take at least 45 minutes to 1 hour for the first consultation.
Okay.
And that is because you need to prepare the patient that this is what has happened to your kidney,
Okay.
and this is the reason why this happened to your kidney. These are the options in front of us. So when the creatinine is 1, 2, or 3, of course you are not going to give them all in one go. You're just going to tell them the basics.
Mm-hmm.
Once the creatinine starts crossing 3 or 4, you start slowly sensitizing them. Or if the first time you are seeing a patient with a creatinine more than 4 or 5, and you know that it is stage 5 CKD, then I make them sit, call the family members, and explain to them that, see, this is the issue. This is your GFR. I show them, we calculate the GFR in front of them, show it to them,
Okay.
and tell them, because a lot of people think that it's only affecting one kidney, right? So they always say that the same question, that, sir, ಎರಡು kidney fail ಆಗಿದೆಯಾ? Have both my kidneys failed?
Okay.
Or is it just one kidney? So that is when
Okay.
you have to again explain to them that, it's not one kidney which fails. If one kidney had failed, your creatinine would still be normal.
Normal, yes.
But unfortunately, both the kidneys, are working very suboptimally, probably failed at some point of time. You have to tell them that. And then you start preparing them that, see, these are the things. Unfortunately, it has happened due to XYZ causes.
True.
If we know the cause. If we don't know the cause, obviously we evaluate. And then you start priming them slowly that, at some stage you will need dialysis. So sometimes it's in the first session that you break through all the news.
Mm-hmm.
Sometimes if you have time, if the creatinine is not so high, you take some time. You first try to make them understand as to what they are dealing with. And then on the next, counseling session, try to break it to them that, see, the treatment is not seeming to work,
Yeah.
and you're probably having an end-stage kidney disease. So it's a tough task, but
I
you have
agree.
to spend time. That the only way you can convey it to the family members and the patient is by spending some time with them, trying to understand their perspective, and then breaking the news to the family.
True. It is an unenvious job to put it very mildly.
Yeah.
So hemodialysis is a very important management tool for CKD end stage kidney disease. But once you make that call and once you talk to the patients, I have seen during my residency period, immediately they feel it as bad as a cancer diagnosis,
Right.
and they feel that this is a malignant um uh, cancer with multiple metastases kind of mindset, and they start going into alternate therapies.
Absolutely.
And I have seen many people going into alternate medicine and landing up with more problem with heavy metal
Toxicities.
toxicities. So, what's your experience in this?
Yes. So, rightly said. I've had multiple patients because we've practiced in a government institute where, just as you said, that as soon as you tell the patient that, your kidneys have failed, and as I told you, we had hardly 10-15 minutes of that OPD time that we could give to our patients, and we would have to disclose it to them that your kidneys have failed. As soon as you say that, your creatinine is 6 or 7, your kidneys have gone, you have to start preparing for dialysis. Please get an AV fistula created. That's our patent, dialogue, that, you prepare them for the end stage renal disease. And of course, once they go out of the OPD, we write a set of medicines, send them out of the OPD. And this patient, one of my patient, I still remember, this may have been back in around 2018 or something. They go probably to some alternative medicine.
Yes.
Maybe his creatinine was 5 or 6 when I would have seen him. He comes back to us maybe a couple of months later, gets admitted to the ward with a creatinine of 17, hemoglobin of 6. And then we ask him that, where did you disappear for the last 2 months? What exactly happened? Why didn't you get the fistula created? He's like, sir, we went to a native medicine. We went to Ayurvedic, or, let's
Ayurvedam, Unani, homeopathy,
all forms of alternate
all
medicines. Yeah.
forms. And even I have seen one of my patient, despite me counseling him to go to a nephrologist, he going to a nephrologist, suggesting dialysis to him. He's not willing. Even went for magnetic therapy. He used to carry magnets on his fingertips.
Wow.
I was like, what benefit
So,
will you?
see, unfortunately, I don't have anything against the native medicines. I mean, these have originated from our country, and we need to respect all the forms of medicine, alternate forms as well. Unfortunately, there are people who are at rampant practicing, in the name of these alternate medicines, they are practicing something of their own, and we don't know what exactly they are doing.
They should have a limit. They should understand that, okay, this is a CKD case who has come to me. And the alternative medicine health practitioners should tell the patient saying that, no, this is not going to work out. If it's some psoriasis or maybe chronic bronchial asthma or dermatitis,
Absolutely. Yeah.
so those conditions, okay, fine. They are not life threatening. Okay, they are discomforting, and
There should be a line, as you say, there should be a line beyond which they should refer it back, to the allopathic medicine. And yeah, I mean, allopathy doesn't have anything in it. We don't have any medications to cure it. So we are
that's
not
true.
saying that, we will cure your chronic kidney disease. But there are alternative forms of therapy. There is a renal replacement therapy. There is transplantation. So why play with the life of a patient? So there have to be boundaries, I feel. So unfortunately, that is not practiced. So
Because it is just a tipping point is there, and they're already very fragile, and
absolutely.
they land up in a bigger problem. We cannot recover them. ICU stay, the cost goes up.
Yes.
This is a very nasty situation.
Absolutely. So yeah, when we counsel them for an AV fistula creation, immediately they feel that we are going to start dialysis, and they, promptly go to other forms. They try to find out other alternative ways, where they can try to get benefit. So I tell my patients that you want to go for Ayurvedic medicine or any other native medication, no problem, but please create your AV fistula. Please keep a regular check on your tests. Every 15 days to 1 month, you keep a check. I don't have anything against anything. If they are going to be able to give you a treatment, great. Because you don't want to discourage them, but you make sure that you make them aware of what they at least need to do, even if they are going for those things. So that tomorrow, if a need for dialysis arises, we at least have a fistula ready for it. We don't have to admit them and put a jugular catheter and dialyze them. It's better if they already have a fistula. It's easier that way.
All right. One thing I have seen, and I felt a little, I didn't understand the logic, is nephrologists, for example, in this case, you see CKD cases and you start feeling that the patient is going to dialysis.
Yes.
You start preparing the patient to go to dialysis. The same patient I have not seen nephrologists so aggressively talking about kidney transplant. So, in your experience or in your daily clinical practice, when do you initiate the talk of transplant?
Right.
In what set of patients do you initiate this talk? Do you initiate it with the dialysis or during that time?
Right.
So, just a small.
So yes, as we are discussing about when we start a topic of transplantation, it all again depends upon how much time you have in your first consult. As soon as you have diagnosed a patient having chronic kidney disease and you are aware that this patient will require dialysis, the same setting you can give them the option. And usually I do the same thing. I tell
Okay.
them that these are the two options in front of you.
Okay.
One is dialysis and the other is kidney transplant.
Mm.
Of course, now the comorbidities of the patient, the age of the patient needs to be considered. I would not give the same advice to a patient who's 60, 65 years of age.
Definitely.
Though there are people who can undergo transplant at 60, 65, but yeah, I mean, I would not tell them as the first option, right? So I would definitely tell a younger patient who's between 30 to 60 years, definitely you give them these two options in the first visit itself, wherein you tell them your kidneys have failed and these are the two options in front of you. Of course, if the creatinine levels are very high, it's usually a dialysis first, followed by transplantation.
Transplant.
Very rarely we counsel them regarding preemptive transplantation,
Okay.
which is doing a transplant of the kidney before they end up into dialysis. Very rarely. Most of the patients that we see or encounter, we dialyze them first and then prepare them for transplant.
Wonderful.
So yes, coming back to that question, that we try to counsel them in the first setting itself. If that is not feasible, then of course once they are on dialysis, based upon their age group, you definitely start counseling them immediately in the next couple of weeks itself. For the first month of dialysis itself, you are going to counsel them about the transplantation need.
Wonderful. So, coming to another important aspect that I wanted to your opinion on it. Painkillers are one of the very important causes for going into interstitial nephritis and then kidney failure.
Right.
I have also seen rampant PPI usage.
Yes.
That is also a very important cause.
Yeah.
So, but this is a chronic condition and people tend to use this. So, this is a two-part thing that I want to understand. One is how frequently do you see PPI-induced renal failures? And second, the newer molecules, that is PCABs, which have come in the market, potassium channel acid blockers.
Yes.
What is the evidence on them for on kidney?
Right. So as you said that proton pump inhibitors, yes, there is literature on proton pump inhibitors causing interstitial nephritis, and a lot of people are rampantly using it for long periods of time.
True.
Fortunately, we don't see as much cases of interstitial nephritis clinical practice. In my clinical practice, at least, I have not seen too many cases of interstitial nephritis being attributed to proton pump inhibitors. But again, there's a big question mark, because there are a lot of interstitial nephritis that we see, but we don't know really the cause. So we cannot directly attribute it to a particular thing unless it is an acute interstitial nephritis. The only drug that they are taking is a proton pump inhibitor. Then you can still attribute it to the PPI. But otherwise, when there's a mixture of stuff, because as you know, interstitial nephritis can be caused by infections
Yes.
and a lot of drugs, right? So a lot of patients have a mixture of these things. So it's very difficult to attribute it to PPI directly. But yes, we know that it can cause.
Yes.
And wherever possible, any particular medicine like proton pump inhibitor or NSAID, chronic use should be discouraged. Having said that, there are some of your patients, probably my patients as well, who have these, GERDs or chronic gastritis, and the day they stop the PPI, the next day they have the symptoms. So unfortunately, in such patients, you can't do much. You have to tell them and pray that they don't develop interstitial nephritis. And with respect to the newer molecules, I have not read much articles about them causing interstitial nephritis as yet. Probably in the future we may get
The
to know about,
evidence will
we may
come.
get some more evidence about whether they are also able to
Long-term
cause
data is
interstitial.
still not there.
Absolutely. So once we get long-term data, we will know more about that.
Okay, good. So this is something that I have read, and this is something that's true. We have amyloidosis.
Yes.
People who are under hemodialysis for longer duration, they can develop beta 2 amyloidosis. which can cause severe mortality, morbidity, and mortality.
Yeah.
The newer dialysis techniques have come up which will prevent this. If you can share a little light on this.
So, yeah, dialysis technique, the newer trend is towards hemodiafiltration,
Yes,
right?
that is what.
So, this combines hemodialysis, that is, the concept of diffusion, which was mainly was clearing the smaller molecules, is combined along with convection. Now, convection basically is useful in removing the middle molecules. So the smaller molecules include your urea, creatinine, and the electrolytes, whereas the middle molecules include the inflammatory mediators as well as the beta 2 microglobulin.
Okay.
Right. So when the clearance of beta 2 microglobulin improves, the inflammatory mediators improve, overall mortality, morbidity, it
Benefit is
also
there.
benefit is there, and the amyloidosis chances also reduce. So this newer modality basically is your hemodiafiltration, wherein a lot of centers now are switching over to hemodiafiltration for better patient outcomes.
Okay. So, what is the difference in equipment wise?
Right.
Is there a major difference in equipment, training, cost wise for this process compared to regular hemodialysis?
Definitely, the equipment varies because the dialysis machine changes.
Okay.
The machine that we use for conventional hemodialysis, of course, they are from the same company, but the machine changes. Number one. Number two, the dialyzer changes. The low flux dialyzer changes over to a high flux dialyzer. So the pores are more efficient in clearing out middle molecules. The hemodiafiltration basically, when you're removing the molecules via diffusion, you're also doing something called convection. That is, you're doing solvent drag. That means you're giving large amount of ultrafiltration is done, so that along with the fluid, the middle molecules also get dragged out. And then you have to give replacement fluid also.
Okay.
Either it is given before the dialyzer, that is referred to as pre, or after the dialyzer, that is referred to as post.
Okay.
So one change happens is in the dialysis machine. Second change happens is in the dialyzer itself. The third thing is you need very high blood flow rates. So dialysis catheters may not be easy to do it. You need proper good fistulas for a hemodiafiltration.
Wonderful.
And the fourth change which happens is there is a substitution or replacement fluid which is generated online in the machine. So this substitution fluid also needs to be an ultra pure form of water. So these are the changes technically which are happening. Of course, requires additional training for your staff because all staff are currently trained for hemodialysis. So you need to train your personnel. The cost goes up almost double. If the hemodialysis can happen in a good center at 2 or 2,500 rupees, the hemodiafiltration will happen around 4 to 4.5 thousand or 5,000 rupees per session.
Wonderful. Now, naturally, my question is, when you say that it removes a lot of inflammatory molecules, has it any role in ICU setup, especially when you're dealing with sepsis kind of condition?
Yes.
Do you feel any role is there for this technology in that?
So, of course, there are certain forms of dialysis where, which help in septicemia, wherein, you have polymyxin B absorbers and the dialyzers which can, remove the molecules or the inflammatory mediators itself can be removed. So those are also available. Definitely hemodiafiltration, if a hospital is having it for the normal patient, definitely it will benefit the ICU patient as well because the hemodynamic stability will be better.
Okay.
Because you're using a substitution or a replacement fluid, so large volume of shift will not be happening. Having said that, something called continuous renal replacement therapy, CRRT, will be the ideal for a patient who is in the ICU, who is usually having a hemodynamic compromise.
Okay, that's great to hear. Wonderful. So, coming to a, a thing that I'm more curious about, because we are Indian doctors, we treat Indian conditions,
Yes.
Indian patients.
Yes.
And what we read is mostly Western
Data.
So, tell me about a case or a patient or a kind of situation that you were in, which was so unique. You thought it was one thing, it turned out to be an entirely different thing. And it kind of changed your perspective on a whole.
So, of course, in these many years of practice, there are multiple cases like that wherein, we would have started off thinking of one particular condition and ended up completely in a different direction. But recently, I mean, what comes to my mind first when you ask me this is recently I had a patient.
Mm-hmm.
It was referred to our center, a 25-year-old girl,
Mm-hmm.
referred to our center. She's about 5 months post-delivery.
Mm-hmm.
She was sent to us for evaluation of nephrotic syndrome.
Okay.
She had, diffuse swelling in
All over
all over
body.
the body, and she's come at midnight. I see her the next day during the rounds, and when I look at all the labs that what are the labs, there was no evidence of nephrotic syndrome.
Mm-hmm.
There was no proteinuria.
Mm-hmm.
I was like, okay, then why has it been sent to nephrology?
Mm-hmm.
Anyway, the case was for us to evaluate, so we started the evaluation. Her albumin level was 1.1,
Okay.
severe hypoalbuminemia, and she had a history of cough for about 1 to 2 weeks.
Okay.
And of course, the swelling, generalized swelling all over the body was there, which was also there for 2 weeks. So it was a very short duration history she had. It was not like
Okay.
she was suffering from months.
Mm.
And when we traced
This
back
was
her
post-pregnancy.
post-pregnancy, 5 months postpartum. So when we traced her pregnancy records, because usually, I mean, what we have been trained is you look at when the patient was absolutely normal. So track back from that point and understand what is the chronology of events that have happened. That helps you in
What kind
understanding
of
it.
delivery was this? A normal delivery
It
or
was a normal delivery,
vaginal delivery?
vaginal delivery. And when we tried to trace back the report of during her pregnancy, everything was fairly okay. And the child was also doing fine. So then I was thinking that, okay, now what could the cause
Not
of
anuric.
this?
She's
She was fine. Her kidney parameters were normal, normal renal function, albumin was very low, but there was no proteinuria. So we were, quite perplexed in understanding that why is this albumin so low, and what else could be triggering it. So during the workup, the iron profile was sent and stuff because she had anemia.
how
Yeah.
much was HP?
So the other tricky part was she had pancytopenia.
All right.
So she had low hemoglobin, low WBC count, low platelet count.
Everything is going toward liver.
So yeah, I mean that's what we thought, that probably if is there any liver cirrhosis or something like that. During our workup, we saw that the ferritin level was very high. It was
Okay.
1,700.
Okay.
And the LDH level, we had done it because of course she had cytopenias. That was around 2,000.
Okay.
So ferritin LDH was very high. The D dimer came as around 1,700.
Okay.
So again, it was quite everything. Nothing was fitting. What has the patient been sent to us for, and what are we trying to evaluate here? So it was completely going in the opposite direction. Slowly, we started realizing we had just sent, incidentally, because she had cough, we had sent her sputum analysis.
Okay.
X-ray was unremarkable actually.
All right.
Sputum AFB came positive.
All right.
So she's a case of pulmonary tuberculosis without any doubt. We did a CT thorax to understand, because X-ray normal, we just wanted to confirm. CT thorax showed classical features of pulmonary tuberculosis. Then we started understanding that, there was pancytopenia. There were increased inflammatory markers like ferritin, D-dimer levels. She had high triglyceride levels.
Okay.
Then we thought that is it a possibility of, HLH, hemophagocytic lymphohistiocytosis.
Okay.
And, to our surprise, it actually turned out that she had HLH. The criteria was fitting in. And then we traced back reports. Can there be association of tuberculosis with HLH? And of course, there are a lot of records and reports of tuberculosis causing HLH. And we started ATT for her. We gave her diuretics. We gave her albumin infusions. Around 5 albumin infusions we gave. Fortunately, she was covered by, the
Insurance.
state, the national insurance actually.
Okay.
So fortunately, we could give all the possible treatment in her. Today, in fact, we, could discharge her as well with the treatment. She's much better now.
Okay.
So very interesting case.
Yeah, because yes.
You're taken aback completely.
Yes,
because,
I am speechless.
For me, being a nephrologist, something like this, to get through all of this was quite challenging, because we don't see these cases usually. As a physician, we would have seen these kind of cases. But yeah, it's like you never know what is coming your way.
This is really, it makes me go back and read more about ALH.
Yes.
Nice. So, coming to, what should the general population do to, take care of themselves? What is your advice for people who have family history of CKD, hypertension, and diabetes? What care should they do apart from exercise and diet? And what I'm more interested in is investigations like yearly health checkups. what investigations do you advise people who have crossed 35?
Right. So it's a very valid point. In today's world, what I suggest for anybody who's crossed 30 itself, I tell them yearly health checkups. Though age is no barrier, unfortunately, at any age you may need, annual health checkups. But at least reasonably enough, I tell them at least post 30, you need to get annual health checkups every year, which needs to include everything, including your hemoglobin, I mean CBC, RFT, urine examination. Now, specific to nephrology per se. So, when I see a patient with diabetes or hypertension, or somebody who's having a family history, or somebody who's having cystic kidney disease in the family, I give them handouts. So, I've made certain handouts for diabetic patients that these are the tests you have to undergo yearly.
Okay.
So, in that, we include the annual health checkup, includes the cardiac screening. So, get an echocardiography done, ECG and echo. So, if any further, doubts are there, then you can get the TMT. From renal perspective, we ask them to get a urine routine,
Okay.
microalbuminuria,
Okay.
and an RFT yearly.
Mm-hmm.
The next being neuropathy and retinopathy. So we ask them for a fundus examination yearly. And of course, neuropathically, if they have any symptoms, then we tell them.
Okay.
So these are the usual things. So heart, kidney, the retina, and the lipids. So these checkups annually I tell them to get.
Okay.
This is for all my patients with diabetes. A handout is given to them and explained.
Everybody above 30 years.
Absolutely.
Wonderful. There is this saroglitazar, triglycerides lowering drug. Do you use that in your practice a lot?
Not much, frankly.
Not much
No,
at all.
Not much of it.
Okay, good. So, sir, this has been a very, very informative session with you, especially the case that you discussed.
Thank you.
Is going to stay with me for a long time.
Thank you so much.
And it has, again, most probably I'll go back and open my Harrison again and read more about it.
Yes.
So, this is kind of a great challenge for you, especially treating CKD cases in India. I understand, I have seen, I have worked with nephrologists, and you're doing a great job, great service to our country.
Thank you. Thank you so much.
And I thank you for coming to the podcast, sir.
Thank you so much. It was quite interesting having this conversation with you. I mean, you've been a great host to us, and thank you so much for all the insights that you could convey to people who are listening to this podcast. Thank you so much for your time.
Thank you, sir.
Thank you.